You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about Pacemaker and ICD Interrogation. We will cover pacing modes, sensing, threshold, impedance, single and dual chamber timing, battery status, and an integrated approach to interrogation. This episode and the next will likely comprise no more than 2 or 3 questions on exam, but I feel it is important to know because these are fundamental concepts for interrogating, programming, understanding pacemakers and ICD in the general cardiology setting, even if you're not practicing in EP. So let's jump into pacing modes. What do the letters mean? The first letter is the chamber paced, and the second letter is the chamber sensed. The choices are A for atrial, V for ventricular, and D for dual chamber. The third letter is the response to the sense beat. The choices are I for inhibition, T for trigger, which is theoretical, and we would not really do this often, and D for dual response. Okay, so A, V, D for the first and second letters, I or D for the third letter. There's a fourth letter, which we'll talk about later in this episode. There are 3 types of single chamber pacing modes that are commonly used: VVI, AAI, and VOO. VVI is ventricular demand pacing. It's the most common one among single chamber pacing modes. Although VVI pacing protects the patient from lethal bradycardias, it does not restore or maintain AV synchrony, nor does it provide rate responsiveness in a patient with chronotropic incompetence. VVI mode is used for AFib most commonly. Because AV synchrony is absent, the rate of pacemaker syndrome is quite high at 83%. Then we have AAI, atrial demand pacing. This is pretty uncommon. AAI mode is appropriate for patients with sinus node dysfunction who have intact AV conduction. A sense atrial event will inhibit atrial pacing. An expiration of a preset AA interval will pace the atrium at a preset rate. Because there is no ventricular support if AV block should occur, careful testing of AV conduction is necessary at the time of pacemaker implantation. You do this by incremental atrial pacing. Next, we have VOO, asynchronous ventricular pacing. You pace the ventricle at a fixed rate without any regard to anything that is happening because you are not sensing any chamber and you are not responding to any sensing. VOO, this is the mode that the magnet will change the device to if you place a magnet on a patient with a device. So if there is an intrinsic ventricular event, that is not sensed and it does not interrupt the pacing interval. The number after the mode can be interpreted as follows. If somebody says VVI 60, that means the lower rate timer is 1000 milliseconds long, i.e. 1 second long, because a lower rate timer of 1000 milliseconds corresponds to 60 beats per minute. So VVI 60 will pace the ventricle every 1 second if it is not inhibited. Now, there are 3 types of AV sequential pacing modes that are commonly used: DDD, DDI, and VDD. DDD is the most physiologic mode. The pacer can be totally inhibited in normal sinus rhythm or can pace the atrium in response to a spontaneous ventricular depolarization, or can pace the ventricle in response to a spontaneous P wave, or can sequentially pace both the atrium and ventricle. This mode is most appropriate in patients who have impaired AV conduction, including third-degree heart block with either an intact or dysfunctional sinus node. That's DDD, the most physiologic mode. Then you have DD. There can be both. There's both atrial and ventricular sensing and pacing, but no atrial tracking can occur in DDI mode. The pacemaker rate is therefore fixed, so this mode is rarely used. Then with VDD, which is also an uncommon mode, ventricular stimulation can either be inhibited by a spontaneous ventricular beat or be initiated by an atrially tracked beat, and it can therefore be used in patients with normal sinus function but impaired AV conduction. This modality uses a floating sensing electrode in the atrial portion of the ventricular lead. The two most common that you need to know overall from these six that I told you about are just VVI and DDD. If you know just those two, you should be good for most of the cases that you're going to encounter. VVI is ventricular pacing on demand with a single lead in the right ventricle, and the sense ventricular beat inhibits ventricular pacing. Is most commonly used in chronic atrial fibrillation with symptomatic bradycardia, as I mentioned. And DDD is the one with atrial and ventricular sensing and pacing. The native atrial beat inhibits atrial pacing and actually triggers ventricular pacing. This is tracking of intrinsic atrial activity. It maintains AV synchrony. That's why the third letter D can exist. It's inhibiting the atrium and triggering the ventricle. And then VOO and DO is pacing at fixed rate regardless the intrinsic activity. Okay. Then there are some four fancy modes, including rate adaptive pacing, mode switching, and managed ventricular pacing. These are three concepts that are different and should not be confused. What is rate adaptive pacing? Rate adaptive pacing adjusts the heart rate based on physiological demand, for example, during exercise or stress. It uses sensors such as accelerometers to detect activity levels and increase pacing rate accordingly, mimicking the natural increase in heart rate with exertion. Motion sensors, sensors for vibration, acceleration, gravitation, and motion, are the most common sensors. Impedance sensors are also common. For example, minute ventilation sensors, respiration sensors, or stroke volume sensors. Minute ventilation sensors are prone to interference from electromagnetic sources, coughing, hyperventilation, and arm swinging. The purpose is to ensure that the heart rate is appropriate for the patient's activity level, improving exercise tolerance and quality of life in patients who cannot increase their heart rate naturally due to chronotropic incompetence. When you have that fourth letter R, for example, AAIR, VVIR, or DDDR, the pacemaker will increase the pacing rate in response to physical activity. For example, when you go from sitting, sleeping, to walking, to running, if the patient does not already increase his or her rate. Now, how about mode switching? Mode switching is a feature that automatically adjusts the pacemaker's mode in response to atrial arrhythmias, such as AFib, aflutter, ATAC, or paroxysmal SVT. When a rapid atrial rhythm is detected, the device switches from atrial tracking mode, such as DDD or DDR, to a non atrial tracking mode like DDI or VVI to prevent the pacemaker from tracking and inappropriately pacing the ventricles at the high atrial rate during these episodes of supraventricular tachycardia. What about managed ventricular pacing? Managed ventricular pacing is designed to minimize unnecessary right ventricular pacing in patients who have intrinsic atrioventricular conduction by using the intrinsic atrioventricular conduction when it is present. Why does this matter? Because prolonged ventricular pacing causes adverse outcomes due to ventricular dyssynchrony, causing LV remodeling, reduced ejection fraction, pacemaker induced cardiomyopathy, and even death in patients with an already reduced EF. The device alternates between atrial based pacing, AAI, when intrinsic conduction is present, which minimizes side effects from unnecessarily prolonged RV pacing, and dual chamber pacing, DDD, which provides safety in the event of AV block only when necessary. In other words, it will, at baseline, do atrial pacing, and when it senses AV block, it will switch to mode DDD. That's managed ventricular pacing. It's possible to have both rate adaptive pacing and managed ventricular pacing set. You would program it as AAIR DDDR mode instead of AAI DDD mode. When people say AAIR plus, that mode refers to AAIR being able to switch to DDDR. When people say AAI plus mode, that refers to AAI being able to switch to DDD. The equivalent to Medtronic's rate adaptive pacing modes is rate adaptive pacing or minute ventilation sensor in Boston Scientific and rate response in Abbott St. Jude. The equivalent to Medtronic's mode switch is the atrial management system or AMS, sometimes also the atrial tachy response in Boston Scientific, or the automatic mode switch, also abbreviated as AMS in Abbott St. Jude, or the smart mode switch in Biotronic. The equivalent to Medtronic's managed ventricular pacing modes is Rhythm IQ in Boston Scientific, Ventricular Intrinsic Preference or VIP in Abbott St. Jude, or Closed Loop Stimulation or CLS and VP Suppression in Biotronic. In these Pacemaker and ICD episodes, whenever possible, I'm trying to give you the equivalent features from each manufacturer so that you can recognize these concepts when they are mentioned and you can be prepared to interrogate devices from any manufacturer. The mode you want to use for each common arrhythmia is as follows. If there's third-degree heart block, use DDDR. If there's sick sinus syndrome, use AAIR or DDDR. If there's permanent AFib, use VVIR. Let's talk about magnet placement. Magnet placement temporarily changes the pacing mode to an asynchronous mode such as DOO or VOO. In addition, the pacemaker will slow to a certain preset rate. For Medtronic, when you place a magnet on it, the rate will go to 85 beats per minute if the device is at its beginning of life, or BOL, and it will gradually become slower with time. If it is 65 beats per minute, that indicates it is the recommended replacement time, or RRT. For Boston Scientific and Abbott St. Jude, at the beginning of life, magnet placement will make it pace at 100 beats per minute. At the recommended replacement time, the magnet placement will make it pace at 85 beats per minute. For Biotronic, at the beginning of life, magnet placement will make it pace at 90 beats per minute. At the recommended replacement time, magnet placement will make it pace at 70 beats per minute. Great, so we've covered pacing modes. Now we'll move on to sensing. Sensing is the ability of the pacemaker to see when intrinsic depolarization is occurring. Anything below the number of volts we set for sensing will be invisible to the device. Acceptable P wave sensing values for the atrium are more than 1.5 millivolts acute or more than 1.0 millivolts chronic. Acceptable R wave sensing values for the ventricle are more than 7.0 millivolts acute or more than 5.0 millivolts chronic. If you want to, quote, decrease the sensitivity of the lead, you should actually increase the number of volts at which you sense so it sees less. If you want to, conversely, increase the sensitivity of the lead, you should decrease the number of volts at which you sense so it can see more. You only want to sense P and R waves and reject T waves, which the pacemaker can mistake as an R wave. You want to reject far field events, which are R waves sensed by the atrial channel, which the pacemaker thinks are P waves mistakenly. You want to reject skeletal muscle myopotentials. These are electrical signals from the pectoral muscle, which the pacemaker may mistake as P or R waves. You also want to reject crosstalk, signals from the pacemaker meant for the other chamber. For example, a ventricular pacing spike sensed on the atrial channel. The sensing circuit consists of an amplifier leading to a bandpass filter leading to a rectifier, which takes the absolute value of all signals so you only get the magnitude based on the direction. And then that is followed by passing it into a threshold. ICDs are able to auto-adjust sensitivity in response to certain events in order to sense fine VFib waves while avoiding sensing of T waves, chamber crosstalk, and pacing artifacts. What do you do when you do a sensing test during interrogation? You need to first uncover the patient's intrinsic rhythm before you can measure the atrial and ventricular sense amplitudes. You do this by temporarily altering the lower rate, AV delay, and pacing mode to uncover intrinsic events. If the current rhythm is A-sense V pace, first increase the AV delay in an attempt to promote intrinsic conduction. If ventricular pacing is still occurring at an AV delay of 350, change the mode to VVI and gradually lower the lower rate, being cautious of patient symptoms. If the current rhythm is A pace V sense, gradually lower the lower rate, being cautious of patient symptoms. If the current rhythm is A pace V pace, gradually lower the lower rate and also extend the AV delay. If ventricular sensing is not produced with an AV delay of 350 milliseconds, change the mode to VVI, being cautious of patient symptoms. And if the current rhythm is A-sense V-sense, then nothing needs to be done because the patient's own rhythm is already present. The sensing test ends automatically after a few seconds and restores the original program settings if no intrinsic events occur and no changes are made to the pacing rate. If the patient becomes symptomatic, click on Abort Test and the sensing test will end immediately and the programmed parameters will be restored. What to set sensing values after you have done the sensing test? The normal safety margin for sensing is half. In the atrium, we set our safety margin to be half the height of the measured P wave. For example, if the P wave is 3 millivolts tall, atrial sensitivity is 1.5 millivolts or less. In the ventricle, we set our safety margin to half the height of the measured P wave. So, if the P wave is 8 millivolts tall, the ventricular sensitivity is 4 millivolts or less. That's sensing. Now we'll move on to threshold. Threshold is the minimum amount of electrical energy needed to consistently capture the heart outside of the heart's refractory period, aka stimulation threshold or pacing threshold. If a pacing pulse does not capture the heart muscle will not depolarize and a deflection will not occur on the electrogram. All you will have is the pacing spike. There are two components to a threshold or stimulus: amplitude, which is the voltage, and pulse width, the amount of time over which the voltage is delivered. When the amplitude and pulse width are stated together, it is known as output. So the output will be number volts at number milliseconds. The safety margin is programming the pacemaker at a high enough output above the threshold to make sure that we capture the heart consistently. If the patient's threshold fluctuates and goes up higher, we want to make sure that we have enough safety margin so that we always capture the heart when the patient is out in the real world. Imagine the strength duration curve, which has voltage on the y-axis and milliseconds on the x-axis. If you program the device above the curve, the strength duration curve, you will have capture. If you program the device under the strength duration curve, you will have non-capture. Based on the strength duration curve, you know that if you increase your voltage, you can still capture the heart if you decrease the pulse width, and vice versa. If you increase your pulse width, you can still capture the heart if you decrease your voltage. Energy equals voltage squared times T over R. Notice that voltage is squared, but time T is not. Since our voltage is squared, if we double our voltage, we end up using 4 times as much energy. Since our time isn't squared, if we double our duration, we only use 2 times as much energy. Normally, the safety margin is set to 2 times the voltage of the threshold and 3 times the pulse width of the threshold. Low thresholds can indicate a stable lead and help maintain a low pacing output, which increases battery longevity. High thresholds may indicate the lead is stimulating unhealthy tissue, which will force us to program high pacing output, decreasing battery longevity. Acceptable capture thresholds for the atrium are 1.5 volts or less, acute, or 3.0 volts or less, chronic. Acceptable capture thresholds for the ventricle are 1.0 volts or less for acute, or 3.0 volts or less for chronic. How do you do a threshold test? If the automatic threshold results are abnormal or the integrity of any lead is suspect, conduct a threshold test in the atrium and/or ventricle. The threshold test will ask you to choose the test type, chamber, how many pulses to decrement by, and temporary pacing values. In terms of the test type, you can have an amplitude decrement threshold test, pulse width decrement threshold test, or strength duration threshold test. The most common one you will use is the amplitude decrement threshold test. When you do a threshold test, pacing must occur in the chamber being tested to measure the lowest energy needed to maintain capture of the heart. If the current rhythm is A-sense V-sense, perform an atrial threshold test by increasing the lower rate above the intrinsic rate. Perform a ventricular threshold test by shortening the AV delay to introduce pacing prior to ventricular conduction. If the current rhythm is A-sense V-pace, increase the lower rate above the intrinsic rate to perform an atrial threshold test until you capture in the atrium. No action is needed to perform a ventricular threshold test because ventricular pacing is already present. If the current rhythm is A pace V sense, to perform a ventricular threshold test, shorten the AV delay to induce pacing prior to ventricular conduction. No action is needed to perform an atrial threshold test because atrial pacing is already present. If the current rhythm is A pace V pace, you don't need to do anything to lower the rate or AV delay interval because there is no threshold test to perform. If the patient is in atrial fibrillation, do not do an atrial threshold test. If the patient has a dual chamber pacemaker, use the DDD mode to maintain AV synchrony and minimize symptoms during the test. If the patient is V pacing dependent, end the test immediately when loss of capture is observed in order to minimize patient symptoms. How do you set the amplitude after doing the threshold test? Typically, you program the amplitude of the threshold to 2.5 volts or less, but you should always maintain adequate safety margins. An adequate safety margin is 2 times the amplitude threshold or 3 times the pulse width threshold. Amplitude values greater than a cell capacity of the pacemaker battery, usually about 2.8 volts, require a voltage multiplier, resulting in markedly decreased battery longevity. That's threshold. Now let's move on to impedance. Normal impedance is 300 to 1500 ohms. Impedance more than 2000 ohms means lead fracture. Impedance less than 200 ohms means insulation failure. The device will measure its own impedance every few hours. When interrogating, make sure lead impedance is stable over the lifetime of the device. A 30% change or abrupt change to impedance is concerning. Normal resistance is um, a uh, normal resistance is friction caused by the hose and nozzle. If you have low resistance, that suggests an insulation breach. Leaks in the hose reduce resistance, causing premature battery depletion. Impedance values may fall to below 300 ohms when there is an insulation break. Oversensing can be a result of insulation break. In contrast, high resistance could suggest a lead conductor break. A knot in the hose results in low total current flow. There will be high impedance with little or no current reaching the myocardium. Impedance values may exceed 3000 ohms when there is a fractured lead wire. If this is the case, you can change the lead from bipolar to unipolar configuration if the inner conductor is still intact while awaiting lead replacement. That is impedance. Now let's move on to single chamber timing. In single chamber pacing mode, there are always 2 timers running: LRL, the lower rate limit, and one of several types of refractory periods. In VVI mode, the 2 timers are VRP and LRL. In AAI mode, the 2 timers are ARP and LRL. That's the ventricular refractory period and the atrial refractory period. The lower rate limit is the base rate or slowest rate the pacemaker will allow the patient's heart rate to go. The lower rate limit restarts with each paced or sensed beat. If an intrinsic beat occurs before the lower rate limit expires, that beat is known as an escape beat, and the newly restarted lower rate limit is called the escape interval. Sensing. If the patient has an intrinsic heart rate faster than the programmed lower rate limit, then the pacemaker will inhibit pacing and sense instead. Pacing. If the patient doesn't have an intrinsic heart rate faster than a lower rate limit, then the pacemaker will pace at the lower rate limit. So that's how lower rate limit works. Refractory period is a period of time following a pace or sense beat in which the pacemaker will see a sensed event, but it will not respond to the sensed event. This is important so that the pacemaker avoids interpreting a T wave mistakenly as a P wave. There are several different refractory periods. The ARP is the atrial refractory period used in AAI pacing mode. The PVARP is the post-ventricular atrial refractory period, which people will say as PVARP, and a VRP is the ventricular refractory period. What if you have a dual chamber device? There are three timing cycles for dual chamber timing. There's the VV timer, which is basically the lower rate limit. There's the AV timer, which is the AV delay, also corresponding to the PR interval. And the VA timer, which is how long after the V pace should we pace the atrium again. When we program a dual chamber pacemaker, we will enter a VV time and AV time, but we will not enter a VA time because that is automatically calculated. DDD is used when AV conduction is impaired. Both chambers are sensed and paced. Now let's move on to battery status. One of the first things you'll see on the home screen of any manufacturer's device. There will be number of years left, as will be a min and a max. Note the date of device implant. If the battery status is okay, that means it has not reached the recommended replacement time or RRT yet. What happens when you reach the RRT? For Medtronic, when the recommended replacement time is reached, most diagnostic data collection is suspended to conserve battery life, and the device switches to VVI pacing at 65 beats per minute, regardless of whether you have a magnet. For Boston Scientific, when RRT is reached, it switches to VVI at 85 beats per minute and some data collection is suspended. For Abbott St. Jude, when RRT is reached, it switches to VVI at 65 beats per minute and most data collection is suspended. For Biotronic, when RRT is reached, it switches to VVI at 70 beats per minute and most data collection is suspended. Usually, once RRT is reached, the pacemaker can still operate for 3 more months until the end of service or EOS. This is true across all manufacturers. If you have made changes to the settings, you can go to battery status and click measure again or whatever the equivalent button is by manufacturer to re-estimate how long the battery will last with your new regimen of therapies. Now that we have all of these concepts down, let's talk about a systematic approach to interrogation. Start by thinking, is the issue an issue of the generator or leads, or connection between generator or leads, or intrinsic to the system? On the chest x-ray and device integration, look at how many leads there are and in what position. Is it an ICD or a pacemaker? And is there any pneumothorax on that chest x-ray? Know the normal pacing functions and timing cycles, so specific programmed AV delay, device checking parameters, real findings on telemetry, adequate detection rates, and reasonable sensitivity. Then consider noise. Is there any non physiologic artifacts on leads that can be intrinsic or intrinsic to the device? It can indicate a problem with the leads, such as a fracture of the lead or air trapping. Consider failure to pace or output. Consider failure to capture. If the pacing spike is not followed by either an atrial or ventricular complex. If it's within hours to weeks of implant, then suspect lead dislodgement, malposition, premature lead failure, premature battery depletion, or programming errors. If the failure capture is occurring long term, then think about cardiac causes such as lead fracture, fibrosis of inflammation, cardiomyopathy, exit block, breach of insulation, or battery voltage being at the end of life. Then think about sensing abnormalities. Oversensing is when you sense non-cardiac electrical activity and the device is inhibited from correctly pacing. For example, if it thinks T waves are P waves in hyperkalemia, or if it thinks U waves are P waves, that's oversensing. You can also get oversensing from muscle activity, the diaphragm or pectoralis, or if the cell phone is being held within 10 centimeters of the pulse generator. Undersensing is when you incorrectly miss intrinsic depolarization and the device paces. It can come from poor lead positioning, lead dislodgement, magnet application, low battery, or MI. Pacemaker syndrome is when the patient feels worse after pacemaker placement with V pacing, VA conduction, due to loss of atrioventricular synchrony and atrial contraction against a closed AV valve. The patient will present with progressive worsening of CHF failures. You may need to add an atrial lead if it is a single lead device. ICD problems are similar to pacemaker problems, except you'll also need to think about inappropriate cardioversion defibrillation and ineffective cardioversion defibrillation, which we will cover in the subsequent episode on ICD therapies. When you write your interrogation note, a basic note of a complete standard interrogation should include 1. The device and manufacturer, 2. The battery voltage, including the current voltage and a note of the ERI voltage, 3. The full energy charge time, if an ICD is present. Normal should be less than 15 seconds. 4. A comment on the leads. Impedance, the normal range is 300 to 1000 ohms, except in high impedance leads. Sensing, normal is atrial more than 1 millivolts, ventricle more than 5 millivolts. Threshold, ideally the atrium should be 1 volt at 0.4 milliseconds or less. The ventricle should be 1 to 2 volts at 0.4 milliseconds or less. Pacing and sensing percentages. You will see the percent that the device saw A-sense, V-sense, A-sense, V-pace, A-pace, V-sense, and A-pace, V-pace. To get the percent time V-pace, simply add up the percent for A-sense V-pace and A-pace V-pace. To get the percent time A-pace, just simply add up the percent for A-pace V-sense and A-pace V-pace. 6 is the underlying rhythm. Test this by reducing the pacing rate incrementally or suspending pacing as described earlier in this episode. 7 is mode switch episodes. You can either say something like none or a specific number like 3 or 4 or 5, or if it's happening a lot, you can say frequent. 8 is IC tachycardia events. 9 is sensing threshold settings. It should be less than 50% of sensing capability. And 10 is pacing output. You want this set at twice the threshold voltage and 3 times the threshold pulse duration. So we've covered pacing mode, sensing, threshold, impedance, chamber timing, battery status, and interrogation approach. That's all for pacemaker and ICD interrogation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.